Just as we're letting everyone into the room, just like to say welcome. Thank you for joining us tonight. My name is Dr. Lena Nido. I'm the GP Liaison Officer at the Eye Hospital, whom some of you may have met me before. I've certainly been there.
Hi, Lena, you're muted.
Well, you would think that by now, with two years further down the pandemic, I would have learned how to unmute myself. But welcome, everybody. Thank you for joining us tonight. Ideally, we're going to leave everyone, all of the participants, you'll all be muted. And if you need to ask questions, I'll ask you to write those in the chat box as we go along, and I'll be moderating those. My name's Dr. Lena Nido. I'm the GP Liaison at the Eye Hospital. I've been around for a few years there, so some of you may know me. I would like to acknowledge the people of the Kulin Nation, who are the traditional custodians of the land that I'm on today. I'd also like to pay my respects to elders past, present and emerging, and to any Aboriginal people joining us today. I acknowledge and I'm very grateful to the Collier Charitable Fund, who have generously donated funds that help support us bringing you these GP education sessions. Also, our speaker, Dr. Thomas Campbell, thank you for generously giving your time and expertise and sharing that with us. The Northwest Melbourne PHN, who really are providing all of the technical support, RACGP points, and we really couldn't bring you these sessions without their partnership, so we're very grateful to them. Feel free to ask questions as we go, but I'll ask you to write them in the chat box. I'm pretty sure your microphones are all turned off. I'm not sure if you have the power to turn them on, but I'd prefer that you don't and that you actually type into the chat box, or it will get too busy. We are video recording this event, and it will be made available from the Eye Hospital website, as well as the Northwest Melbourne PHN channel. I will email my mailing list when the video recording becomes available. There's also recordings of past events. For those who aren't aware, you can go on there, register yourself with us, and you'll be able to watch all of our past events. Yeah. Could someone mute themselves if they're not already muted? Thank you. Evaluation surveys. So a link to the evaluation survey will be provided through the chat at the close of the webinar. Please complete the survey as soon as possible. We really love getting your feedback. It helps us to plan future events. It's valued, and it's really necessary for us to also provide the RACGP points. And before I go any further, I haven't written it on there, but please save the date for our next event, which is the 4th of May, 7 p.m. to 8 p.m. It's also a webinar. It's about common pediatric infections. Dr. Elizabeth Rose, our beautiful ENT specialist, will be presenting, and she's presented for us many times. She'll be talking about a whole host of common pediatric infections, in particular acute throat infections, differentiating between bacterial, viral, pros and cons of antibiotics, acute otitis media, rhinitis, chronic suppurative otitis media, tips on when to refer, a discussion between the costs and benefits of tonsillectomy, current referral criteria, and how to discuss with patients, including tips on advice for flying, swimming, language development, and more. If you want to register for that, you'll find the registration link on the Northwest Melbourne PHN events section, and later this week I'll be emailing that link out to my emailing list. So if you're not on my emailing list, then I suggest that you write to me, email me at gpliaison@ioneer.org.au, and I can put you on. This is just a snapshot of our website, which has recently been updated. That's the start of the 4GPs section, which is underneath the Health Professionals tab. There's a whole host of resources there, including referral guidelines and forms, GP education, training and events, and previously recorded sessions, contact information, other useful links. And this is the referrals information page. So we've got a host of referral guidelines, forms, and other information. I'm just going to mention Health Pathways Melbourne. Unfortunately, the screenshot hasn't come up on this slide. No, I can't link to it. But essentially, Health Pathways Melbourne, if you're within the Northwest Melbourne PHN or Eastern Melbourne PHN local areas, you can get access to that. If not, I suggest you contact your local PHN. Most areas in Victoria do have health pathways. The statewide referral criteria for eyes and for ENT have been incorporated into pathways to assist you to manage conditions and know when to refer. If you don't have access, then either contact your local PHN or visit this particular website. And so I've missed a slide, but anyway, basically health pathways have got a number of pathways that can assist you to manage conditions with your patients and to know when to refer. The red eye health pathway has not yet been localised, but is certainly on the list of next up to be localised. And there's a number of eye conditions that actually have been localised that are relevant for tonight's talk. So I suggest that you have a look at that at a later stage. I won't go through the learning objectives. Tom can cover that. And I'd just like to introduce our speaker, Dr. Thomas Campbell. So he's a clinician scientist at the Royal Victorian Eye and Ear Hospital and the University of Queensland. He is interested in ophthalmology, medical statistics, evidence-based medicine and medicine in the developing world. He has a particular interest in Indigenous and developing world outreach ophthalmology services and the logistical as well as scientific obstacles to providing cutting-edge ophthalmic care to these communities. He completed an undergraduate degree in ecology at the University of Queensland before moving to the UK, where he completed a Master of Science and Doctor of Philosophy in Neuroscience at Oxford University. He then worked at St Cross College and the Wellcome Trust Centre for Human Genetics at the University of Oxford as a research fellow in psychiatric genetics. In 2010, Dr. Campbell returned to Australia and completed his medical degree at the University of Queensland. He's currently undertaking subspecialty fellowship training through the Royal Victorian Eye and Ear, Centre for Eye Research Australia and the Royal Children's Hospital. So I will stop sharing my screen and allow Tom to speak to you. I'm going to mute myself now, Tom, and unless there are any questions that I may challenge you with throughout your presentation.
So today I wanted to talk about the red eye and corneal emergencies and to give you a framework in which to approach this really common presentation to general care and to emergency departments, and to give you a sense of sort of when to panic and refer on and what can be safely managed within a non-ophthalmic stream of care. So ophthalmology is primus inter pares of the sort of hospital-based specialties, mainly because it's so difficult to spell ophthalmology. And most people in their initial application to ophthalmology spell the name of the specialty to which they're applying wrong. So just make certain you copy this slide and get it right on the referrals. Now, unlike all other specialties, the ophthalmology has its own vital signs, and the vital signs of the eye are just as vital as the vital signs in general medicine and surgery and general practice. We care about visual acuity, visual fields, extraocular movements, the pupils, intraocular pressure, and optic nerve function. But just like the rest of medicine, that we've known since 25 AD, there's only a few actual presenting complaints that come from inflammation or injury to tissue, right? Rubor, tumor, dolor, calor. And that's true of the eye as well. And this is tumor of the eye, so chemosis of the eye. There's redness as well, there's pain, and you can get swelling of the eye and heat within the eye, ocular adnexa. And so all of the signs that you guys are familiar with from the rest of the body also present within the eye, but in a kind of special, different way. So the red eye is just a sign that there is some kind of inflammatory process or insult to the eye. And that can be, ranging from completely innocuous causes, as in there's a little lash that's pointing in the wrong direction, through to the potentially fatal. And so it's really important to have a structure and a framework to try to assess the red eye. And it's something that's really common, right? So Murtagh suggested that it's something like 15% of presentations to general practices are ophthalmic related, and of which the most common is the red eye, and 31% of presentations to the eye and ear ED are for the red eye. And this, red eye is also by far the most common presentation to general EDs for ophthalmic complaints. Now, this is the health pathways framework that Lena was talking about. And in it, there's some really good sections that it is worth trying to get access to this if you're in a PHN that doesn't have access, or if you're in the Northwest Health, it's really worth having a look at this. And within the red eye, there's quite an excellent array of information that will help you triage and manage conditions that present within the red eye. But you kind of want simple rules of thumb. And the two simplest ones are beware the unilateral red eye. Now, that's in Murtagh's general practice, and that's what we practice on a day-to-day basis. So the unilateral red eye should be a warning sign to you. And second one, the red eye, red flag. So it's 2 H's and 4 P's. And we're going to go over this repeatedly tonight. So it's worth trying to remember this one. So pain, photophobia, poor vision, pupil abnormalities, and then 2 history ones, 2 H's, a history of contact lens use and a history of activities associated with penetrating eye injuries. And that's any high velocity, high impact behavior. So especially metal on metal, hammering, drilling, working with power tools, any of those should be considered as a history of an activity associated with penetrating eye injuries. So if you remember those 2 H's and those 4 P's and beware of the unilateral red eye, then you'll almost never go wrong with the red eye and corneal emergencies when they present to your rooms. So just to sort of bed this down, we're just going to go over a series of case vignettes that talking about different presentations of the red eye and how we can use these rules of thumbs and the red eye, red flags to arrive at a kind of diagnosis, or to arrive at a point where you say this person needs to either be managed here, it's safe, or needs to be referred to ophthalmology. So a 41-year-old man presents with a 4-day history of red eyes and watery discharge, and his vision is 20/20 or 6/6 in each eye. So we run it through the sieve. Yeah. Beware the unilateral red eye, and remember the 2 H's and the 4 P's. So does he have a unilateral red eye? No, he's got both his eyes are red. Is it painful? No. Does it hurt when he goes out into the bright light? No. He's answering no to all these questions. And so you know that this is something that is unlikely to be very serious. Even if the eyes are incredibly red, they're bilateral and they answer no to all those other questions. By far the most common cause of bilateral red eyes, or even actually the unilateral red eye before it generalizes to both eyes, is viral conjunctivitis, of which the most common cause is adenovirus. Viral conjunctivitis is responsible for 25% of eye presentations to general practitioners. It's usually bilateral and sequential. So, people say that they've got a red eye in one day, feels a bit weird, and then the next day both their eyes are red. It's often accompanied by either an ERTI prodrome or by concurrent viral ERTI symptoms. And there's commonly a contact history. So people say that it's run through their family, their kids came home from daycare or primary school with red eyes, and then everyone in the family got it as well. And so the ocular signs, and these are visible on gross examination, you don't need a slit lamp or anything fancy for this, is red eyes, watery discharge. Now, patients will always tell you that their eyes crust in the morning, and that's just because that the really watery discharge is sitting on the external ocular surface overnight. It dries out, it inspissates, and then you just get left with the proteinaceous stuff that was inside that watery discharge. And so often their eyelids are actually stuck together in the morning, and they get follicles. And follicles are these little sort of, they're described as like little pieces of rice underneath the conjunctival surface of the inner aspect of the lid. So the best way to see them is to use gloves, is to pull the eyelid surface down so that the eyelid is everted out. So you just pull on the cheek, you evert the eyelid a little bit, and then you look along the aspect of it and you see that it's corrugated. It's got these little rice-like bumps on it. Those are follicles. It can also be associated with pseudomembranes, which is essentially like, it looks like a really adherent layer of pus on the, this is called the bulbar, the palpebral conjunctiva, so the conjunctiva of the lid. And you can get little subepithelial infiltrates, which is essentially little tiny bits of graying of the cornea, but you need to see that under a slit lamp. It's viral conjunctivitis is wickedly contagious. And it's sort of the fear of all private ophthalmologists. They call it the private practice ender, because you can have someone come into your room and they can give every single person in the waiting room and all of your staff viral conjunctivitis. And then, your whole rooms have to shut down for days to weeks on end. So it's wildly contagious. Definitely wear gloves. Wear a mask for these people, and you try to get them in and out of your practice as fast as possible and decontaminate any surface that they've touched. Definitely give them a medical certificate so they don't go to work and give it to everyone around them. And you can give lubricating or just artificial tears that you buy at the chemist or over the counter for comfort. But there's nothing else to do for these patients. So then here's another case. A 41-year-old man presents with a 4-day history of red eyes and mucopurulent discharge with a burning, gritty feeling. And his vision is 6/9 and 6/18. So it's not a unilateral red eye, but he does have pain, that burning and gritty feeling, and the vision is down. So 6/9 and 6/18 is not normal vision for a young man. And so this should sort of, these two red flags should start the alarm bells ringing. And this is bacterial conjunctivitis. So bacterial conjunctivitis, we think of it as being common, but in fact, it's vanishingly rare. It's less than 5% of all the conjunctivitis that present to the eye and ear will be bacterial conjunctivitis. Most commonly, sort of the bugs that you imagine, Strep pneumoniae, Staph aureus, H. influenzae, and Moraxella can cause it. But there's one that's everyone has to know about. So gonorrhea, the STI, can cause a potentially blinding form of bacterial conjunctivitis. And it's characterized by marked mucopurulent discharge. So this picture here on the bottom right with all this sort of mucopurulent discharge on the outside, that is not an exaggeration. Their eyes can actually, you can clean them, and within the few minutes that you consult with them, the eyes will refill with mucopurulent stuff. It's really horrific to see. But if you miss it, they can penetrate the bug, Neisseria, can actually get through an intact cornea and cause a corneal perforation within hours. So you have to have a super high index of suspicion for really severe conjunctivitis with lots and lots of mucopurulent discharge. Ask about a history of STIs or high-risk sexual behaviors, because if you miss it, they can go blind overnight. You know, if you see them in the afternoon and you refer them to an ophthalmologist the next day, they can sadly actually perforate overnight. They do really, really badly. So they need local and systemic treatment because they've got gonorrhea, and they need a workup for other STIs as well. So it's got red flags, and that is the cue that you know that you need to at least discuss it with ophthalmology. So here's another case, a 61-year-old man. So he's got a one-day history of red eye, pain, and reduced vision. And you can see that he has a unilateral red eye. He's describing pain. And when you look at it with either stain or even just grossly, you can see that there's this little white fleck in the inferior aspect of the cornea. Now, you often think that you need a slit lamp to examine the external surface of the eye. You really don't. You just need a light, and it's made easier with a magnifying glass. So even your dermatoscope that you look at skin with, as long as you just get good magnification, you can see most of the signs that are important in diagnosing external eye disease or corneal pathology just using high magnification and a high light. You don't need a slit lamp for them. Obviously, a slit lamp helps, but don't feel that you can't diagnose it if you don't have this. So this person's got multiple red flags. So it's a unilateral red eye, it's painful, their vision's changed, and ominously, they have a history of contact lens use. And this is a corneal ulcer, so an infective keratitis. So conjunctivitis, you know, is an infection of the external surfaces of the eye, and generally it doesn't penetrate the epithelium. But infective keratitis, infection has got through the epithelium of the cornea, and now it's starting to eat into the stroma of the cornea. And the cornea is only about 0.5 millimeter thick, so you don't have much leeway or much tissue to get through before you start getting really serious problems within the eye. And this is super common. On average, there's one or more a day presenting to the eye and ear. And again, similar kinds of bugs, Staph epidermidis, Staph aureus, Strep pneumoniae, and then depending on climatic conditions where you are, but in Victoria, Pseudomonas is not common, but in Queensland, where I am right now, Pseudomonas is sort of about 50% of the infective keratitis that comes through for us. And Pseudomonas is a severe and potentially blinding form. And you have to think about it all the time in people who have been wearing contact lenses, and especially people who've been to tropical climates. Even just Queensland or northern New South Wales counts. Even northern Victoria is good enough. And you can just get it in Melbourne as well. It's just less common. Characterized by rapid onset, severe pain. The vision is normally down, but can be normal. But the big thing is that people are in lots of pain. Like, they really do not feel good. And contact lens use. And contact lens is by far the most important risk factor for corneal ulcers or infective keratitis. And it's by far the most important prognostic factor for outcomes from microbial keratitis. And these require same-day ophthalmology input. So what we do is we do a corneal scrape, where we use a little razor blade to take samples from the eye, plate them up on different media, and it's sent away, and then they get put on hourly drops overnight and daytime for 48 hours. And we need to see them again within at least 48 hours, but often we'll see them the next day or admit them. So infective keratitis, people with a red eye in the setting of contact lens use, need same-day ophthalmology input.
Sorry to interrupt, Tom.
Yep.
It was interesting. I was reading a case recently where the point was made that you really do have to ask patients about contact lens wearing, because they may not volunteer the information. And this was a case where, now I don't completely understand this well, but the child was wearing lenses overnight to try to stop the shape of the growing eye or cornea to reduce the amount of myopia or something that was developing. Does that make sense? So they weren't even sort of thinking of it as a contact lens wearing. Yeah, so it was just interesting that don't forget to ask.
And that's my next slide. So
okay, but I wanted to also interrupt you, sorry, because somebody else has written a question with regard going back to conjunctivitis. And I always find this interesting. Do we swab for both viral and bacterial conjunctivitis?
So no, I don't swab for viral conjunctivitis. It's a clinical diagnosis. It picks up adenovirus, but most of the time, you know it's adenovirus anyway. The pretest probability is very, very high that a conjunctivitis is viral, and it doesn't change your management at all. Now, if there's lots of mucopurulent discharge, you're concerned, then yes, I would do a swab, and but to be honest, I would do a swab, but I think in general practice, I would just get them seen by an ophthalmologist or to present to an ED, so that we need the swab to be reviewed overnight. So if I think someone's got gonorrhea, I will wait until someone has performed microscopy on the swab in real time. So we send it across, and a scientist comes in and looks at it in the next couple of hours, and I will institute treatment straight away if they see anything that looks like gonorrhea. So no, I wouldn't perform swabs. I would get them seen if you think, by an ophthalmologist, if you think it's bacterial conjunctivitis, especially if you think it's gonorrhea. But by the time the swab results are back, they've either lost their eye from gonorrhea or they're better, and it's not going to contribute to your management. Yeah,
thank you.
So contact lenses, it's really important to ask questions about contact lenses, specific questions, because people don't volunteer that information a lot. And what Lena was talking about is called orthokeratology. And essentially you wear a contact lens at night that binds closely to your cornea, and it changes the shape of it. And so then you don't need to wear glasses as much during the day, the next day. It's pretty controversial because it's obviously sitting really tightly on the eye. That's how it works. It changes the shape of your cornea. And your cornea is an avascular structure. So it gets its oxygen from the air during the daytime. So oxygen freely diffuses into the tear film and then into the cornea itself. And in the nighttime, because your eyelids are shut, the oxygen has to come out of the blood vessels on your conjunctiva, get into the tear film, and then diffuse across all of the cornea to provide nutrients to the corneal cells. And so at nighttime, the cornea is the only bit of your body that kind of gets worse overnight. Everything else gets rested, the cornea gets worse. So wearing a contact lens at night is really bad news. And so we ask those questions. So are you wearing contact lenses? What sort? So disposable or non-disposable? And if disposable, daily, weeklies, or monthlies? And essentially, there is a factor of 100 in terms of the risk of getting a blinding or potentially blinding infection in the eye between non-disposable contact lenses and then monthly disposables. So it's an absolutely enormous difference, and one that's really worth knowing when we're making risk stratification and prognostication about their outcomes. And so if they're not wearing daily disposables, say weekly or monthly, you want to know, where are they in the life of the lens? They put it in today, or do they put it in 29 days ago, and it's been sitting, festering, and getting worse and worse and worse? Contact lens hygiene, how do they use it? How do they store it? How do they wash them? And then the big one is, do they ever clean them in fresh water or swim in fresh water? Because there's a terrible bug called Acanthamoeba, which can get into people's eyes. Contact lens wearers classically who swum in fresh water or clean their lenses in fresh water, and essentially people go blind, often with treatment, and the treatment is pool cleaner and chlorhexidine that you put in the eye hourly for often months on end. So it's the most terrible disease. So you need to ask those questions so that we can prognosticate about the potential for Acanthamoeba, but also work out what other bugs there are. Now, there's myriad presentations and ranging in severity from these small little paracentral infiltrate here That's not going to knock the vision around at all. It will be symptomatic, but the outcome from this is going to be fantastic. To central, moderately sized lesions. So this is right in the visual axis. So it's almost certainly going to cause scarring from this ulcer, in which case, even if you treat them perfectly, often they'll have vision loss anyway. And then the end stage, which is that the eyes start to sort of just melt. They turn into a large abscess, and the inner surface of the eye becomes filled with pus. And this can happen, in 24, 48 hours if left untreated. So it can be really, really bad disease. So people with a red eye, unilateral red eye in the setting of contact lens use need same-day ophthalmology input. Here's another unilateral red eye. So a 61-year-old man, 4-day history of red eye, discomfort, reduced vision. And when you put in fluorescein staining, you see this beautiful lesion here. So again, it's got red flags. It's a unilateral red eye. It's painful, and the vision is normally knocked around in these cases. And this is, of course, a herpetic keratitis. So normally HSV1 causes this. It's really common. It's really common both in terms of its prevalence, but also its incidence. So lots of people get it, and lots of people get it multiple times. So really often recurrent. And those recurrent cases are often managed by the patient themselves. They've just been given a prescription. And so we don't see a lot of those cases. So it's a lot more common than you will give it credit for. And the important thing to ask about is a history of cold sores. Do people get recurrent cold sores? They've got poor immune control over herpes viruses, and they are the people who often get these recurrent infections. At the end stage of the disease, it's no longer painful. And it's because you just burn out the trigeminal, the V1 and the corneal nerves from continually being infected. And so the cornea becomes denervated. So you can push on the eye and they don't feel it at all. But the problem is they don't feel their infections. And often because they've got scarring, their vision is already poor. And so they don't notice the new events. And so they can get just this gradual accretion of damage. And it's really bad because it's very difficult to do corneal grafts in these people because the herpes virus continues living in their eye, and they often just get recurrent infections even if you do a graft. The treatment is topical acyclovir ointment 5 times a day until 3 days after the lesions have resolved. And so normally, I just say about 13 days for most people. It normally heals within 7 to 10 days. So giving 3 extra days on top of that, 13 or 14 days of acyclovir ointment. If you see a pseudo, or dendritic lesion like this, fluorescein staining, they've had it before, they've had a history of cold sore viruses, I would just start them on acyclovir ointment. This is a case where a swab is really useful in these circumstances. So just send away a swab for the herpes viruses because it gives you a molecular diagnosis, you know what you're treating, and you're good to go from there. You can treat it with oral Valtrex as well. So it's a relatively high, so it's 500 milligrams TDS if, the patients aren't able to use gel. They've got bad hands, bad rheumatoid arthritis, they're old, they're unable to get it in their own eyes, or if they're immunocompromised. So it's just worth knowing that you can just give them tablets if they can't take the gel. And if it's recurrent, taking 1 tablet of Valtrex a day essentially halves the chances of recurrence per year. So from 24% to 12%. So the number needed to treat to prevent 1 episode is 16.5, which isn't that bad, especially given that 1 Valtrex a day has minimal morbidity associated with it. So just as a rule of thumb, if a person has 2 episodes in a year, I put them on 1 year of Valtrex prophylaxis, 1 tablet a day. If they have an episode on prophylaxis, they stay on it for life. If they don't have an episode in that year on prophylaxis, I give them 1 year off it. They have an episode again, they go back on Valtrex for life. And I just repeat that process. So essentially, you have to work your way into not taking Valtrex prophylaxis for life.
Sorry, Tom, to interrupt.
Yeah.
It's Lena. I just wanted to ask, is that in the PBS? Does that qualify for PBS? No, so they're on a private script?
It's on a private script, but actually it's no longer expensive. So it used to be $40 or $50 per box. And now at Chemist Warehouse, it's far cheaper. You can get the 100 boxes for relatively cheaply, and that's what you give them to take for the year. So it's a private script, but it is one that saves them in the long term.
Awesome.
Yeah.
And I'll just read out a couple of other questions to you. I think you're probably going to speak about herpes zoster, but the question was, is hepatic keratitis related to herpes zoster?
No.
No, it's not. It can occasionally be a little difficult to tell the difference, or no?
You can actually get pseudo-dendritiform lesions in herpes zoster, but the classic thing with zoster is that they have the V1 distribution rash.
Yeah.
It's the ones who don't have the rash that are really difficult to work out. But
yeah.
you can get pseudo-dendritiform lesions in herpes zoster, but in general, you won't get the two confused.
Okay, awesome. And there's a couple other questions, but I'll leave those to the end.
Yeah, it's just worth knowing in the setting of epithelial herpetic disease, unopposed steroids are blinding. So if you give steroids, even low dose surface acting steroids like Flarex or FML, you just lose all immune control on the eye surface, and you get essentially this terrible disease where the herpes goes crazy, and then you can just start rotting the surface of the eye. So unopposed steroids in the setting of herpes, blinding. And that's why I think unless you have achieved a definitive diagnosis, I would never suggest giving steroids without knowing exactly what's going on, because there's lots of people who've been blinded by unopposed steroids in herpetic keratitis. So just to change tack a little bit, the red eye, we've been talking essentially all about external eye disease, and that's what we kind of think about most of the time, and that's what that the red eye is in general most of the time when people present external eye disease, infections or trauma to the external surface of the eye. But here's a 51-year-old lady, a 4-hour history. So this is, hyperacute, red eye, pain, a 9 out of 10 headache, nausea, vomiting, and reduced vision. And you can see that her pupils are abnormal. So this pupil is a different size to this pupil. It's a unilateral red eye. It's painful. There's pupil abnormalities and there's poor vision. And this is the classic story, is that people see rainbows around lights when they get this. This is acute angle closure glaucoma. And this is relatively common. It often doesn't present to the GPs because the symptoms are so fulminating. People describe these awful headaches. They feel absolutely miserable. Nausea and vomiting predominate. They often go down a subarachnoid intracranial pathway before someone twigs that the eye is the problem, because the headache and the nausea and the vomiting often predominate over the eye pain. People just have this poorly localized pain in that region. And there's one a week present to the eye and ear, and it can blind people in hours. And what it is that the fluid is produced essentially behind the iris, the aqueous humor of the eye. It goes out through the pupil, and then it goes in front of the pupil and out through the what we call the angle of the eye, which is just here in between the white bit and the colored bit of the eye. And if people have certain anatomical predisposition, the pupil can block off the angle. So it's essentially like when you get you pull your curtains back in the morning and they bunch up on the outside. So instead of being pulled tight and being flat, they all get bunched up together. And if the space in that angle is too small, then the bunched up iris blocks it all off. And then they produce fluid, which pushes the iris into the angle more, which blocks it in even worse, and you just go into this cycle. And essentially, the pressure just becomes sky high inside the eye until you just infarct the eye. And the really good rule of thumb is that if you check a pressure, if you have some mechanism to check pressure, or the optometrist checks pressure, and the machine is unable to read a pressure in that eye, it's because it's sky high. So often people say, oh, the pressure is normal in this eye, but we just can't get a reading. So we assume that there's some problem with the machine. The problem is the eye. The pressure is too high for the machine to read. And these people need same-day review. And what we do is we reduce the pressure with anti-ocular hypertensive medications, and then we fire a hole through the iris with a laser, and it allows a second passage of communication of fluid out through the back of the eye into this front area, and so it can get out again, and it breaks the cycle. And if they have this anatomical predisposition, the other eye is at risk. And so we give them pilocarpine, which brings the iris in. It's like pulling the curtain shut, so it pulls them tight into the middle, and so they don't bunch up at the edges. The story that people give is that they walk from brightly lit environments into dark environments, and they get eye pain, headache, and they see halos around lights. And that's because they walk from a lit environment where their pupil's really small into a dark environment. The pupil massively expands, and then it starts blocking off the angle, and they start getting symptoms.
Sorry, Tom, someone asks, are the disposable tonometers generally accurate? In brackets, green, yellow, red.
They are really good screening tools. So they are excellent screening tools in that they can give you a kind of sense of that it's high or not high. That's about as good as they are.
Great.
Yeah. So again, a 41-year-old man, a subacute presentation, 4-day history of red eye, pain, marked photophobia, and reduced vision. And when you look into the eye, you can see that there's pupil abnormalities. So this pupil is smaller than this pupil, and that there's sort of these little white deposits on the back of the eye. And you'd be able to see this again with a bright light and magnification. And the big thing is in this condition is that when you shine a really bright light into people's eyes, they absolutely hate it. They're incredibly photophobic. So they often come in with glasses on, with a hood and a hat over their eyes. And so this photophobia often predominates in terms of their symptomatology, pain and photophobia. And this is acute anterior uveitis. And again, this is an incredibly common condition. We see hundreds of these a year at the eye and ear. And people who get it tend to get it recurrently. So people will often get an episode every single year, from their teenage years all the way through into their elderly, into old age. So recurrent, very common, very symptomatic. So people really feel awful with this, like intense photophobia. So describe it as, when light gets into the eye, it's like being hit in the eye, and essentially they're getting ciliary spasm inside the eye, and it's really painful. It's often meiotic on that side. The pupil is smaller and often irregular. Like, can you see this sort of weird pupil shape here? And it's because the iris gets scabbed down by all the inflammatory debris inside the eye onto the lens itself. And that's called synechiae. And that's a really classic sign of uveitis. Big clue, and it's really worth using this, is the pain is not relieved by topical anesthetics. So it's a really good test. Put topical anesthetics in, the pain goes away. It's ocular surface pain because the topical anesthetics like oxybuprocaine or Alkane or Tetracaine or whatever you have in your rooms is really excellent surface acting, but doesn't penetrate the eye at all. So this will not be relieved at all by topical anesthetics, whereas say corneal abrasions, corneal ulcers, those things are often relieved by topical anesthetics. They need at least same-day discussion with ophthalmology to plan treatment and follow-up. They don't necessarily need to be seen the same day, and we can actually start. We'll just give you a plan about starting intense cycloplegia, so making the pupil really big and paralyzing the muscles of accommodation, which cause that photophobia, and intensive topical steroids, so often hourly, day and night for at least 48 hours. The big thing here is you need to ask, and you need to ask closely about recent surgery or injections to the eye. So if someone has a red eye and inflammation in the eye after recent surgery or injections to the eye, this is endophthalmitis until proven otherwise. And they need same day, sort of within several hours, review by an ophthalmologist. So endophthalmitis is actually incredibly common. We have at least one person on the board at any one time with endophthalmitis at the eye, and it's because injections into the eye are incredibly common. So there are thousands of people in Melbourne being injected every single day, not the same people, but every day there are thousands of injections being done into people's eyes. And they're not done in theaters, they're done in sort of semi-sterile conditions, but in people's rooms. People wear sterile gloves and clean the eye, but but it's just in people's rooms. So there are infections that come along with it. There is a risk. The number is low. It's 1 in 6,000 or something, but there are thousands upon thousands of injections and cataract surgery and intraocular surgeries being performed a day. Now, most of the time, luckily, these people don't present to general practice. They come back to their ophthalmologist or they present to an ED. But it's always worth asking in the setting of inflammation inside the eye whether they've had something done recently, because your chances of recovery are measured in hours. So the time to get antibiotics into the eye is the single most important feature other than the bug inside the eye for your eventual prognosis. Go, Lena.
Thomas, someone asks when you say recent, how recent?
Yeah, so classically, it's 48 hours, or 24 hours to 48 hours, and then up to 7 days. So 7 days seems like a long time ago for an infection to kick off inside the eye, but that's really common. So within a week, if they've had an injection within a week, definitely it's an endophthalmitis until proven otherwise. Within 10 to 14 days, I would discuss it with the place that did the injection, whether it's a private ophthalmologist or a hospital, because they'll want to see them anyway, because there are indolent bugs like P. acnes and a few other skin bugs that cause these sort of just grumbling infections within the eye. They don't get that same fulminating presentation. Unfortunately, fortunately, that the infection is much less severe, but unfortunately, it's really difficult to eradicate those indolent bugs. And so often they just get recurrent infections as soon as you stop them off their drugs, and it just comes back. So it can be really bad.
Yeah. Right. And just to let you know, there's 12 minutes left.
Perfect. So the red eye rules of thumb. Beware the unilateral red eye, and remember the red eye red flags. So 4 P's and 2 H's: pain, photophobia, poor vision, and pupil abnormalities. A history of contact lens use, or a history of activities associated with penetrating eye injuries. If you remember those red eye red flags and beware the unilateral red eye, then you're always going to be safe. This is a very sensitive tool to triage eyes. It's not necessarily specific, but it is very sensitive. You're not going to miss anything bad if you follow these red eye red flags and beware of the unilateral red eye. Sure, you might send through some viral conjunctivitis, which have not yet become bilateral, but that's much better than missing a gonorrhea or a acute angle closure glaucoma. Just as another tip, there's always an eye registrar on at the eye and ear ED. So 24 hours a day, there is an accredited ophthalmology registrar available to give you advice. So if you're working on a weekend, there's multiple ophthalmologists on at any one time. If you're seeing someone late at night, there's always someone who can give you advice. Just call the eye and ear hospital and get asked to put through the registrar. And we give advice essentially across all of Victoria and then into neighboring states as well, because so we're the people who are definitely awake and definitely on call and the easiest number to remember. So just if in doubt, give us a call and we'll be able to give you advice over the phone. So I've got some questions, and then if you wanted, I can just give you a tiny thing on ocular trauma as well at the end, which is 2 slides. But we'll go over the questions first, and then I'll show you the trauma at the end.
Have you got a slide on chemical burns?
I do not have a slide on chemical.
Okay, so there's a question. I don't think this is a quick question, or maybe it is. For chemical burn of the eye, after rinsing with water for 20 minutes and starting Clausig, do they need to be seen by ophthalmologist same day? I'll answer that, yes.
Yeah.
Yeah. And when examining patients, do you always use a fluorescein stain? I would say yes as well.
Yeah. It's really useful how much stuff you pick up with fluorescein.
Absolutely. And I'll just
people's eyes. I'll just tell you, I've rinsed people's eyes for 6 or 7 hours before. Yeah. So 20 minutes is not necessarily enough.
Yeah, that's first aid. Yeah.
Especially with alkali. So alkali are things that they penetrate into the tissue and then they leach back out. So you wash the eye, you check the pH, it's normal, and then you check the pH 20 minutes later and it's 12 again. So you just need to keep washing those people. And if you transfer them, especially if you transfer them at distance, they will go blind en route. So The solution to the pollution is dilution. Like, you just wash them, and we're not going to do anything clever other than wash them as well. So the main thing is washing them until their eye pH in particular has normalized, and then you can transfer them. But you can do that sort of in your general practice. Don't put them in an ambulance for an hour, because they will go blind in the ambulance.
Absolutely. And I know, I mean, obviously, if you don't have normal saline, you'd use whatever you had. Tap water, what are your thoughts about that?
So essentially, anything you put in the eye, water-based, is going to be better than what they have in their eye.
Yeah.
So you wash it with whatever you have. You know, you've got bottles of water, you've got a tap, you've got a pool. You know, that is what you wash the eye with, because it's incredibly toxic to the eye. A lot of these chemicals, like oven cleaner and those things, that you just got to clean the eye. You just got to get it out of the eye, neutralize the pH, and then we can sort the problems out in the future. Yeah.
All right, I'll try and get through some of these earlier questions quickly. Is there any change in pupil size in infective keratitis?
Yeah, so you can get miotic pupils, and again, it's a similar mechanism to the uveitis. Essentially, the eye just becomes inflamed inside, and then you get ciliary spasm, and the pupil becomes smaller. But it is normally subtle and really difficult to assess. So it's not a prominent feature. The prominent feature is that you see a big infiltrate on the surface of their eye that looks nasty, and you see fluorescein staining when you put it under the blue light.
Yeah. And if in the after hours a patient with any of the red flags, should we send the patient to ED with an ophthalmology service?
Yeah, and in Melbourne, you send them to the eye and ear, because there's a 24-hour eye ED that has there's an ophthalmology registrar there 24 hours a day.
And do you recommend instilling local anesthetic in every painful eye?
No, but it can be used to facilitate examination. So there's lots of times where people just won't let you look at their eye, in which case you need to put local anesthetic in. And it is useful in distinguishing the location of the pain. Is it topical surface-based pain, or is it intraocular pain? So it's useful in that scenario. What I don't recommend, and what I counsel strongly against, is people going home with local anesthetic, because the eye is a funky tissue where corneal health is reliant on neurotrophic cytokines that are released by nerves. And if you numb the nerves, they don't get those neurotrophic cytokines, and the cornea just starts dying. For this reason, we have no idea why it's set up that way, but it is. So don't give them local anesthetic to go home.
Yeah. And that probably feeds into a question about anything else to do in flash burns from welding lamps other than oral analgesia.
Yeah, so I would get them seen, because often the other thing that we can do is that we can give them bandage contact lenses, which sometimes helps. So that's a contact lens we put over the cornea itself, and it stops. Think about it, like your eyelids are running over this damaged tissue sort of 30 times a minute when you're awake. So it's really, really painful. But if you put a contact lens, then essentially it glides over the contact lens. It's much less painful. It slightly increases the risk of getting infection, but the reduction in pain in some people is so profound that, like, they're absolutely miserable. You can't control the pain even with high dose oral analgesia, and you can fix it with bandage contact lens. But again, I would only get an ophthalmologist to do that.
Oh my goodness, the questions are coming in so fast, I can't quite keep up with them. So my apologies if I miss any. Any contraindications apart from allergy anaphylaxis to using local anaesthetic or fluorescein in the exam?
No.
There is a question about allergic conjunctivitis, but I feel like that is a whole another topic about how to manage it. I'm pretty sure if participants want to have a look at our previous recordings, there's something in one of our recordings about that. I can't remember which one it's in, but I don't think that's a 2-minute answer, is it, Tom?
No, there's allergic conjunctivitis is very interesting. There's a huge spectrum of disease, from blinding, like literally blinding disease, through to completely innocuous. Zatidin eye drops or Patanol are a really good first choice in oral antihistamines, and if that doesn't make it better, then I would get
topical antihistamines.
Yes, so those are drops. No,
Yeah.
Zadit and
You said oral, but I presumed it was
then
a
oral, sorry,
oh.
and then you take a daily Claritine or Telfar, whatever.
Yeah, yeah. All right, and if you have a look in the chat, everybody, the link to the survey is there now, so just make sure you click on that before we close the meeting. How are we for time? We've got 3 minutes left. Is allergic conjunctivitis uncommon? Obviously, no.
It's not. It's very common. Yeah.
Yeah.
And it's very seasonal. So that's the other thing to remember is that it happens in spring Qatar.
Yes. Do I see the? I think that's most of the questions. There was a personal question up back when you were talking about those contact lenses that I can't remember the name of. A person asked, I think they wear day and night lenses, which have changed their life and meant they didn't need laser surgery. Is that bad? I think was the question.
So we see all the bad contact lenses, right? So we don't see the happy people who come in and say, hey, I wear day and night contact lenses and I've never once had a problem. We see the people who have blinding disease from contact lenses. So contact lenses, especially nighttime wear, terrifies me.
Yeah.
So it's 1 in 10,000 per eye per year for monthly disposable contact lenses, the chance of getting a blinding infection. So that seems low, but considering how many people wear contact lenses explains why we see so many, and you're just rolling the dice. And you can do simple things to reduce that risk, like not wearing them overnight or wearing daily disposables rather than monthly. So that's what I would do.
Yeah. I think there's a few more questions I might have time for. Can you use FML for allergic conjunctivitis?
You can, but unless you've nailed down the diagnosis, I would counsel against using steroids, because actually allergic conjunctivitis can be associated with herpetic, like blepharoconjunctivitis. The two look really similar, and you can get epithelial disease from the epithelial herpetic keratitis associated with it, in which case FML is blinding in that situation. So I would try non-steroid based formulations first. Or once the diagnosis has been made and you can use it in conjunction with an ophthalmologist, absolutely. So often I'll write letters to people and say, when people have a flare, please use FML drops 4 times a day for 2 weeks and then taper. And then that's managed between the patient and their GP. They only come back if things are really bad, but just a first time prescription I would counsel against.
Okay. And someone asked, is steroid injection every 3 months for allergic conjunctivitis recommended? And I presume they mean intramuscular steroid injection, not intraocular.
So no, we often do depot injections for certain types of allergic conjunctivitis. So vernal keratoconjunctivitis, especially in young children, associated with terrible things called shield ulcers, and we inject local anesthetic. We inject triamcinolone into people's tarsal plates in their eyelid. So it is an operation associated with high morbidity. So people get cataracts, they get intraocular pressure rises, they get all kinds of problems from the steroids. So unless things are going really badly, we wouldn't do that routinely.
Yeah. And does iritis present as a red eye as well? Yeah.
So iritis is the old term for uveitis. So it's acute anterior uveitis. It's uveitis, uveal tissue, and it's any of the uveal tissues, and the iris is the one that's most likely inflamed in acute anterior uveitis. And they often get a red eye. It can be purple or violaceous, it's often described as. And the classic thing is that they're intensely photophobic.
Yeah. And do you have any concerns or issues with patients starting over-the-counter Clorcig at the suggestion of the pharmacist for conjunctivitis when it's most likely viral?
So the interesting thing about chloramphenicol is that it's not used in any other setting. So bizarrely, despite the fact that it is used just willy-nilly by every single person in the world, there's very little evidence of chloramphenicol resistance developing. So, in fact, there's better evidence of resistance to even crazy things like betadine in people's eyes when they used it before injections routinely. So, yes, I am concerned by the general principle of overuse of antibiotics, especially in the face of something that's clearly a viral infection. But bizarrely, there actually isn't that much evidence of harm arising from it.
Mm-hmm. And we're at 2 minutes over time, but I think I'll make this the last question. Apart from recurrent cold sores, what else in the history or exam to identify herpetic keratitis?
So the dendritiform lesion, once you've put fluorescein in and shone the light on it, you can see it from across the room. Like it's really obvious once you've thought about putting fluorescein in and lighting it up. The other thing is that they often have corneal scarring. So people with recurrent episodes get this sort of like gray, silvery scarring of the front surface of the eye. And when you put fluorescein in, they get negative staining, which is essentially bits of the cornea stick up through the film of the fluorescein. And instead of lighting up orange, it's blue so there's not fluorescein, it's a little ridge of cornea. And so that negative staining, that irregular corneal surface is a really big clue as well. But recurrent cold sores, corneal sensation, I test corneal sensation. Reduced corneal sensation is very strongly predictive of herpetic disease. Yeah, awesome. I'm not going to give you any more questions. I don't think there are any. We are 3.5 minutes over time, but I personally am happy if you want to do the last 2 slides because I think it's all really valuable information. Yeah, so I'll just this is really simple. Penetrating eye injuries, the big thing is pupil abnormalities. And instead of being smaller or bigger, they are misshapen. And the pupil points to the problem is the mnemonic that you need to remember. So this tear-shaped pupil, if you look at it from the side, you can see that it's actually plugging a wound. So bits of iris go up and they plug the wound inside the eye, and then it stops the leak. And essentially the eye is sealed. So people can have 20/20 vision, almost no symptoms, and have a hole in their eye. It's just that it's plugged by the iris. If it's not sealed, you get the classic waterfall sign or Seidel sign. You put fluorescein in, and then you get this negative staining. You see a rivulet of fluid, aqueous humor, flowing out of the wound, and it disrupts the fluorescein. It's very distinctive. It is very sensitive. It's very specific. It's probably like 100% specific, almost, for a penetrating eye injury, but it's not very sensitive. So there's lots of sealed wounds, or the eye is so badly damaged that there's no fluid left in it to leak out. So it's worth knowing this sign, but it's not the be-all and end-all. Presentation's often subtle or it's horrific. And both times, it's really important to think about the eyeball, that it could be a penetrating eye injury. Think about hammering, metal on metal. People are hammering, a nail. They get a little foreign body kink in their eye. Often doesn't hurt at all, and they've got a hole in their eye with a piece of metal inside it. And the metals are often incredibly toxic inside the eye, and if you don't get them out, it will blind them. And then the other thing is that they're often awful looking problems, and people only care about the eye because it's so disgusting to look at, and everyone's disgusted by eyes, and then they forget that there's lots of important structures in and around the eye. And so this is a person, ophthalmology is called, but they don't think about calling neurosurgery. But the things that go in often go up into the brain. So I saw a woman who fell over onto her high heel and had a little lid laceration. They asked me to suture up, and her high heel had gone way up into her, way into her brain, essentially hit the top of her skull. So don't be distracted by the hideous eye, and make certain that you think about all the other things that could be going wrong with this person. And then they need urgent referral to the eye and ear, or to the nearest trauma service that has ophthalmology. And you need to put something over the eye that doesn't touch the eye. So not a pad. A pad is bad. You need something that will be vaulted over the eye. there's all kinds of eye shields that exist, but you can make it out of the bottom of a styrofoam cup, or you can get a pair of glasses and strap the glasses onto the people's eye. All you want to do is stop them touching the eye and like putting pressure on and burping out the intraocular contents. You keep them nil by mouth, and then you give them, if you have it in your room, ciprofloxacin, ondansetron, morphine, and tetanus prophylaxis, so that stuff's all sorted by the time they come in, and then we can do put their eye back together when they get into the eye and ear. And that's it.
Awesome. Excellent. Well, thank you so much. So just a reminder, everybody, to do the evaluation survey. The link's just gone back up on the chat. Sign up for my emails, gpliaison@india.org.au. PDF handouts hopefully will be emailed later this week. Tom, are you happy? Sorry, I should have checked with you for PDF of your slides to be emailed out to people. Yeah, awesome. And what else? Don't forget to register for our next event coming up in May, which is on ENT, common pediatric ENT infections. I will email my list when video recordings have become available. And whilst you're waiting for that, have a look at some of our other videos. Thank you so much to Dr. Thomas Campbell for his excellent presentation. Thanks also to Sadia and Selena and the team at the Northwest Melbourne PHN for all of their support in bringing this webinar and their ongoing support for our GP education program. Thank you all for attending, contributing, and for staying a little bit late. Any final words? That's all great. So I'll just say good night to everybody. Thank you so much.